many studies have shown that the association between unwanted pregnancy and poor pregnancy care not only leads to immediate childbirth complications, but has longer term impacts on education and other things. So you can see that the pandemic not only has exacerbated the inequities in delivery of care received between the well off and the marginalized, but can also put progress back in terms of achieving equity in health across the board.
I'm JB Wogan from Mathematica, and welcome back to On the Evidence, a show that examines what we know about today's most urgent challenges and how we can make progress in addressing them. In this episode, we're going to talk about the state of maternal health care in India. Since 1994, the John D. and Catherine T. MacArthur Foundation has supported evidence-based programs in India that promote reproductive health and rights. As the foundation has phased out its grant-making related to population and reproductive health, it partnered with Mathematica to conduct a cumulative review of its efforts over more than 2 decades to improve maternal health in India. The foundation's maternal health quality of care strategy in India sought to improve the trajectory of health for women, children, and their families. Although the country had already made considerable progress in expanding access to maternal health services, the foundation's strategy placed greater emphasis on improving the quality of these services, which is seen as a contributing factor in the pregnancy-related deaths that still occur today. Because the Mathematica report published in late February, it summarizes the state of maternal health in India up to, but not including, the COVID-19 pandemic. On this episode, my guests not only share insights from the report, but also provide perspectives of how the pandemic has altered facts on the ground. I interviewed 6 people for this episode. Most of what you'll hear will be a conversation with Deepa Nag Chowdhury and So O'Neill. Deepa worked for the MacArthur Foundation for almost 22 years and was the deputy director of the Foundation's India office for 8 years. So directs Mathematica's health research portfolio for foundations and co-authored the final report on the MacArthur Foundation's maternal health quality of care strategy in India. With the Foundation's help, we also connected with 4 individuals whose organizations had received funding from the MacArthur Foundation and continue to work in the areas of maternal and sexual reproductive health in India. During my conversation with Deepa and So, you'll hear clips from my interviews with those grantees. Longer versions of those 4 interviews will also live on the Mathematica site, and I'll provide links in the episode's show notes to anyone who wants to take a deeper dive in understanding the history of maternal health care in India, as well as the way this pandemic is frustrating efforts to improve both access to care and the quality of that care. I hope you find this episode useful. Deepa, as I mentioned in the intro, we're talking today because earlier in the year, Mathematica released an evaluation of the MacArthur Foundation's grant-making efforts in India related to population and reproductive health. Would you mind walking us through some of the historical context here around the research we'll be discussing? What led the MacArthur Foundation to want to focus on maternal health in India?
When the foundation opened an office in 1994, the Population and Reproductive Health Program primarily focused on efforts to build a critical mass of local leadership that could make a difference at the country level, and we did that primarily through grants to individuals. Alongside this leadership program, MacArthur made grants to Indian organizations for actions that promoted the 1994 International Conference on Population and Development that placed individual dignity and human rights, including the right to plan one's family, at the heart of development. Around 2001, the foundation narrowed its grant-making to 2 themes: reducing maternal mortality and morbidity, and promoting young people's sexual and reproductive health and rights. Maternal mortality was observed as the area with the least progress in the previous decade and where the most dramatic differences existed between richer and poorer countries and among the rich and poor within the country. underscoring that the majority of maternal deaths are entirely preventable. MacArthur envisioned that support for work on maternal mortality would increase the chances that women would have safer pregnancies and deliveries, and these improved outcomes were also an indicator of the availability of services that help women make informed reproductive choices.
Okay, so that explains what the foundation was doing in India. What about the cumulative review from Mathematica? As I mentioned again in the intro, the foundation wrapped up its grant making in India at the end of 2019. What did you and your colleagues at the foundation hope to learn through this report? And so feel free to jump in here as well if you have additional comments.
So, as the number of maternal deaths were declining in India, quality of care really emerged as the most pressing issue at this time. At the same time, the foundation was also deciding to wrap up our program, and we were in the process of making our final set of grants in the field. So we kind of dedicated our time to looking at how we could create a momentum around issues around quality. So some of the areas that we focused on was strengthening the supply of quality maternal health services. A second area was building demand for quality services through accountability mechanisms. And a third area was fostering a quality of care agenda through building evidence and supporting advocacy. So these were the three main areas that we supported. When we got Mathematica to do the evaluation, the purpose was really for us to understand the overall progress of the strategy, of how we could improve quality and demand for maternal health services. We also knew that we were going to be leaving the field at the end of 2019. So we intended this evaluation to be instructive to practitioners, to the government, to other donors who are going to continue to do work in the field.
Yeah, and JB, I just wanted to echo something that Deepa said. I think that it's struck by when we started working on this, the responsible grant making that was happening through the foundation in terms of helping the grantees be able to tie up and position themselves to move forward as the foundation was wrapping up its program in India around population and reproductive health, and also thinking further ahead in terms of what it was the field would need to do to keep the momentum alive to continue to improve maternal health quality of care and population and reproductive health overall. So it was a two-pronged approach to make sure the grant making that occurred through the foundation had a life that continued and was sustained, and at the same time provide helpful information to the rest of the field about how such efforts around quality improvement in maternal health should and could be done.
Okay, so that sets us up nicely to talk about findings. So you were the lead author of the report. What are some of the most important takeaways that listeners should know about?
Well, I think that a key highlight from the report and the maternal health quality of care strategy more broadly is that achieving consistently high quality maternal health care is not dependent on just health services and how they're delivered, but requires a bit more involvement. It requires involvement from communities and advocates alike. So it's not just about the health system. While the quality of healthcare depends on having providers with skills in patient-centered clinical care and facilities with the infrastructure to support complex care available throughout the country, it also really depends on communities being ready to get involved in the whole health system process and getting involved with the mechanisms to hold the health system accountable for the care that they're giving. And it also requires that there are advocates and policymakers ready to ensure that the promises of the change that are being asked of them in terms of the health system are actually being done. So without all three of the ingredients, the health system, the community, and the advocates and policymaker, it's hard to make lasting and sustainable progress. And I think that that is the big key message from the report, that you can't improve quality through just the health system alone.
I want to spend the remaining part of this conversation focused on the present and future state of maternal health in India. The research we've been discussing so far was conducted in a world before COVID-19. But I'm wondering what the pandemic means for the country's efforts to improve the quality of maternal health care in 2020 and beyond. As I mentioned at the top, in August and September, I spoke with a few MacArthur Foundation grantees who continue to work in the area of maternal health in India, and they provided some on-the-ground updates about what it's been like since COVID-19 hit. One of the people I interviewed was Vinoj Manning, the Chief Executive Officer of the iPass Development Foundation, where he works to increase access to comprehensive contraceptive care and to improve the environment for safe abortions. Vinoj told us about the moment that he came to understand, on a personal level, how much the pandemic would affect maternal health care in the country. It was mid-April. By that time, the country had announced a nationwide lockdown of services in response to the pandemic, and the public sector had shifted its focus to managing COVID-19.
So during that time, there was this woman in rural Jharkhand, state in India, who wanted an abortion. She had already 4 children. She got pregnant and she didn't want to continue with the 5th pregnancy, so she went into a hospital. She stayed there for 4 days, but the doctors were too busy to provide services. She came out and started looking at other facilities further away from her home where she could probably get an abortion and couldn't find one. She went on to continue her unwanted pregnancy. That's when it personally hit us as to how big it is, and it put a human face to the story.
The unintended consequences of the lockdown period on access to maternal health care services is something we heard about in several of our interviews. Before I get your thoughts on the decreased access to services during the lockdown period, as well as the delayed effects on demand for services afterwards, I want to play a few more clips. The first is from Renu Khanna, who is a co-founder of the nonprofit Society for Health Alternatives. Renu told us that even though women in India are entitled to free deliveries if they deliver at a public facility, because of the lockdown and the diversion of services to the COVID-19 response, those free deliveries essentially weren't available, and the cost of delivering at a facility, as opposed to delivering at home, went up.
My organization, Sahaj, actually did a study on 180 deliveries during the lockdown period. What we found was that many more deliveries were happening in the private sector because the public sector was completely diverted to COVID tracing, testing, and attending to COVID cases. Or they were in a flap, they were in a confusion about, and they didn't know. So they were neither attending to COVID cases nor were they attending to routine cases. And what we found was costs in the private sector were very high and quite exploitative.
Renu also mentioned some other concerning trends during the lockdown period, such as reduced use of contraceptives, which might lead to higher rates of unintended pregnancies, unsafe abortions, and even higher rates of maternal mortality. And she mentioned that there were fewer C-sections during the lockdown, which could indicate that women who needed the procedure to survive delivery didn't have access because they couldn't deliver in a facility. Or it could mean that fewer unnecessary C-sections were being performed. We don't know. I want to play one more clip for you, and this is from Dr. Sharad Iyengar from Action Research and Training for Health, which is a nonprofit public health organization focused on women's reproductive health. Sharad says demand for routine maternal health checkups has seen a 180-degree turn since he first started working on these issues in the 1990s. Back then, one encounter sticks out in his memory. He was visiting a pregnant mother in a rural village, and when he recommended that she get a checkup, her family dismissed the idea, explaining that they would only seek medical care if she experienced a complication during delivery. An incident this spring during COVID-19 crystallized for Sharad how much things have changed.
During the coronavirus pandemic in the early days, we had this stark example of a woman newly pregnant who apparently had walked 2.5 hours to reach our health facility. That was because transport had been shut down by the government. She walked all the way to get a pregnancy checkup and then walked back. I was stunned by the fact that she would walk 5 hours back and forth just to get a simple antenatal checkup. This is the value today that women attach to pregnancy care. And I'm talking of illiterate women or very less educated women who haven't had the benefit of a lot of exposure to modern ideas. That commitment has come over about 2 decades. The same commitment has translated into most women, almost all, I would say, around 80%, delivering in health facilities.
In a weird way, that story from Sharad is heartening because it shows how much pregnant mothers value routine checkups today. But we also heard that the pandemic is dampening some of that demand for services. I'm going to play a clip from Aparajita Gogoi, who is the executive director of the Center for Catalyzing Change, a nonprofit focused on gender equality and access to quality reproductive and maternal health care. The center conducted a survey of more than 12,000 women in July to find out what's happening in their lives related to reproductive and maternal health care.
So, what women told us first was that, of course, it was difficult to access services. In many places, services were not available because, understandably so, the health workers, the frontline health workers, were dealing with COVID-19. Taking note of people who are coming in from other states, going home, doing home visits, taking temperatures, running quarantine centers. So, obviously, they were extremely busy with COVID. So, routine services like maternal health was taking a back seat. The second thing that women told us via this survey was the fact that the Indian government makes free nutrition available to pregnant and lactating mothers. So about a quarter of women were saying that it was becoming very difficult to access the nutrition. However, as people got used to this kind of a new normal, the government has also figured out many ways of ensuring that women get these entitlements, including kind of direct transfer of money into their bank accounts.
The survey also echoed some of what we heard in other interviews about access to transportation being a problem. And Aparajita said women with lower literacy and lower incomes were running into challenges with gathering the required documentation to prove that they had tested negative for COVID-19 before entering a facility. Deepa, obviously the barriers to access and disincentives to visiting healthcare facilities during the pandemic are troubling. To what extent does it have implications for the MacArthur Foundation's long-term strategy to support maternal health care in India? And particularly on this last point about dampened demand, what do you think the pandemic means for the demand sub-strategy discussed in the Mathematica report?
Early in the pandemic, the Ministry of Health and Family Welfare categorized sexual and reproductive health services, including maternal and newborn services, contraceptive services, and safe abortion services, as an essential set of services that should be available during the pandemic. However, on the ground, as you've heard, we had lots of reports of disruptions. And, the disruptions were experienced both on the demand and on the supply side. On the demand side, we heard women were not presenting for antenatal care and outpatient care. Public transport lockdowns hindered access. Financial difficulties during the outbreak affected attendance. Many hospitals have put restrictions on visits of partners and relatives of pregnant women admitted to hospitals for delivery as a preventive measure, and that too kind of induced women to deliver at home. There have also been several newspaper reports of pregnant women being turned away from hospitals if they're COVID positive or if beds are unavailable. Unfortunately, I think there will have to be a significant rebuilding of people's trust in the services available going forward to make sure that there isn't a drop-off in the numbers of women coming in for institutional delivery. On the supply side, I mean, I can see how some of the work that we supported around quality has faced a setback. I think the cancellation of antenatal clinics, screening programs, outpatient clinics, unavailability of patient beds, lack of supplies, including PPE for healthcare providers, companions, etc., will probably need greater attention in the coming years. There's also been, as you heard, significant disruptions in availability of contraceptives and medical abortion supplies. So that too has to be rebuilt.
I think that what Deepa is saying is that the impact of the pandemic goes beyond the disruption in women's access to contraception and other maternal health services. I think that part of the story is that not only were services disrupted in terms of access and quality in the supply chain, but that there's some uncertainty and fear too that stop people from accessing services on the demand side. So it's a double whammy in terms of the impact on maternal health and the wider health system, because you have issues with supply and you have hesitancy in demand. And I just want to add here that poor maternal health doesn't affect one person, it affects the child and family. So a child's physical well-being, psychological well-being, social well-being depends so much on their mother's well-being. So from the outset, a conception that's not wanted, so not having access to contraception and having a conception of that's not wanted leads to a pregnancy that may not have the nutritional needs it should have, and that if women don't want the pregnancy and then don't go in for the antenatal care, then the checkpoints that are used to identify issues in pregnancies and complications and mitigate complications in delivery can really have an impact on the safety of the delivery and the risks in maternal morbidity and mortality. And if a child's mom experiences maternal morbidity and becomes unable to care for the child adequately, what happens to that child? So maternal morbidity and mortality puts a child at risk for poor health, poor nourishment, poor early development, and so on, setting up a child for less than optimal opportunities later on and potentially interfering with the child's ability to thrive and reach their full potential. So you see how a lack of maternal health care due to the pandemic might have dire consequences for the whole next generation and potentially the generations after.
Another theme from our interviews with the Foundation's grantees in India was that the pandemic is exacerbating pre-existing inequities in the country. We heard that it's easier to access maternal health services in urban areas than rural areas, for example. And in our interview with Sharad, he mentioned related factors such as poverty, education, and access to public transportation.
It turns out that there is more dependence on private transport to access healthcare, and private transport is available to the somewhat well-to-do. The poorest rely on public transport, and that has been severely impacted. Even now, the railways are shut, and even public transport bus services have not been restored, and it is quite a struggle to therefore reach facilities, especially for the poor. The poor also tend in rural areas to live in the most interior places. Roads tend not to go to their living quarters that easily, so there is a longer walk and perhaps more of a struggle crossing rivulets and streams and a more difficult terrain to reach a point from where they could perhaps get hold of a vehicle. So one is this big issue of terrain and transport. The other is liquid cash. I mean, in a time of crisis, well, yes, services are free. They're free when you reach the service. Reaching the service starts costing money.
So walk us through why those inequities in access have implications for health outcomes, such as rates of maternal mortality and morbidity.
So I think this goes back to an earlier point that poor maternal mortality and morbidity can have long-term consequences on any population and the next generation. Now, to Dr. Sharad's point, if it's more difficult for people experiencing poverty to access services and other resources to circumvent maternal mortality and morbidity, then there's going to be a disproportionate share of maternal mortality and morbidity in the populations experiencing poverty. So this means that these populations will also have an unequal share or burden of the consequences of maternal morbidity and mortality. So they'll have a disproportionate share of poor developmental outcomes, and other opportunities may not be available because of some of the complications and the consequences from maternal morbidity and mortality. And many studies have shown that the association between unwanted pregnancy and poor pregnancy care not only leads to immediate childbirth complications, but has longer term impacts on education and other things. So you can see that the pandemic not only has exacerbated the inequities in delivery of care received between the well-off and the marginalized, but can also put progress back in terms of achieving equity in health across the board.
Before we drop the equity thread, the Mathematica report talks about how the current push in India for universal health coverage could complement efforts to address inequities in access to maternal health services. So, Deepa, do you mind explaining how efforts to expand health coverage might dovetail with efforts to make maternal health services more accessible and equitable?
Effective coverage of services is one side of universal health coverage, which demands not only availability and use, but also requires that services be of sufficiently high quality to provide the health gains that they are supposed to. And in this regard, I think what the pandemic has shown and what needs to be done is that there's this considerable scope for India to make progress in improving quality. The other part of universal health coverage is financing. So in India, while delivering in public health facilities has become free, but what we are seeing is that women who go to private facilities are continue to pay enormous sums of money because the private sector continues to remain unregulated. The other thing is that we can't ignore the gendered impact of COVID. More women have lost their jobs early in the pandemic. Many of these women were anyway working in the informal sector where they don't have access to insurance. According to the United Nations Development Program, 87 million women and girls in India were living in extreme poverty in 2020 before the pandemic, and this number is expected to increase to 100 million by 2021. It may be the case that the government will have to increase funding for essential services, including contraceptive services, maternal health, and deal with a higher caseload of women who may now want to deliver in public health facilities rather than private.
Yeah, and I want to emphasize something that Deepa said. I think that the universal health coverage would likely have the biggest impact on the private sector, which accounts for about a quarter to a half of the deliveries in India, depending on whether you're looking at rural versus urban settings. Private sector hospitals, as Deepa was saying, aren't regulated, and universal health coverage could really incentivize more consistency in the quality and price across both private and public sector healthcare. And then actually, by making other health services more affordable, help women and their families have money to put toward maternal health services.
Okay, I want to close out today's conversation by talking about gaps in access or quality that still need to be addressed. I'm assuming that some of the problems with COVID-19 and decreased access to services are temporary, but correct me if you think I'm off base there. In a post-pandemic world, taking into account what Mathematica found in its cumulative review, where do we go from here?
Yeah, so quality was the core issue the foundation was looking to improve because despite increased access for some people, rates of maternal mortality and morbidity were not going down. So, one gap area for me that the grantee started to highlight, especially RENU, is the partnership with community and community empowerment and accountability as a key mechanism to improve maternal health and health more broadly. And community accountability doesn't mean that communities are accountable to the system, but really the other way around. That system should be accountable to the community members, the people served by the system. We don't see support of implementation of community accountability mechanisms often, even in developed countries. So this focus on community accountability was somewhat unique for the MacArthur Maternal Health Legacy Strategy, and where what the grants were doing were funding community members to be active in providing feedback and empowering communities to provide feedback to those in charge of the health infrastructure, hiring of doctors and funding, and then these community members were listened to. And who better to tell the healthcare system what it needs to do than the people that are being served by it and living the experiences and the consequences of that healthcare system. So community accountability, I feel like, is a key mechanism that needs to be in place to right the inequities that Vinoj, Sharad, and Renu all talked about. Another part of the issue, though less of a gap area per se, is the potential mindset engendered by the pandemic, where people get conditioned to only seek healthcare if they feel sick. This goes really against the core tenet of public health, which is around prevention. Prevention means accessing services to keep on being healthy. And as alluded to by Sharad, in the time of the pandemic, when you look healthy, why would you go get services? And the consequences is that when you don't look healthy, it might be too late to reverse whatever is going on. You know, if you think about anemia, which is a common issue among pregnant women in India, and when anemia is mild, it doesn't manifest any symptoms. But anemia contributes to about a fifth of perinatal and maternal mortality in India. So you just hope that the mindset will shift back to people seeking health services, even when they don't feel unhealthy, in the example of anemia, and get that antenatal care that they need, even if the pregnancy is going well.
Deepa, is there anything you would add to So's comments in terms of where we go from here?
I totally concur with So's comment about involving the community in whatever changes happen to the health system. In any case, the pandemic has revealed the fragile condition of India's health infrastructure, and I'm hopeful that it will propel greater investments to address routine needs and the new and emerging health needs of our population. Listening to the community and being responsive is certainly, should be a priority going forward. The other thing I would add is maybe this is a time to leverage technology that can keep up with the demands of women's healthcare services. The foundation had funded some innovations on for telemedicine and for antenatal care, as well as some counseling services for women seeking abortion. Perhaps these are some areas that we can continue to innovate. Finally, the evaluation revealed continued quality gaps, like the lack of an effective referral system and adherence to protocols and infection prevention. I'm hopeful that in the post-pandemic period, there will be a greater focus on these issues, because without improved infection control as well as resolving transport challenges, women and their families will really not have trust in the health services.
Deepa and So, this has been a terrific conversation. Thanks so much for your time.
Well, thank you, JB. It's really great to be able to talk about our work.
Thanks, JB, and thanks, So.
Thanks again to everyone I interviewed for this episode. Deepa Nag Chaudhary, So O'Neill, Sharad Iyengar, Renu Khanna, Vinoj Manning, and Aparajita Gogoi. As I mentioned at the top of the episode, we have edited bonus interviews with Sharad, Renu, Vinoj, and Aparajita that are linked to the show notes of this episode. They're also available on the Mathematica website. Each of them have their own take on the history of India's progress in maternal health care, how the pandemic has affected services, and where the country needs to go to improve access to quality of care. We'll also link to a short summary of Mathematica's report on the MacArthur Foundation's Maternal Quality of Care Strategy. You'll find the full report on that summary page. I want to give a special shout out to Mathematica's Emma Pottinger and Leah Caravallo, who provided critical support behind the scenes to help plan this episode and arrange for interviews. Since this is the last episode before Thanksgiving, I also want to express my appreciation for Gwen Olson, who created our podcast logo and produces all of the nifty podcast-related graphics and animations you see on social media. And speaking of social media, I also want to say thanks to Mathematica's Jill Feldman, who spreads the word about every episode of the podcast on Twitter, Facebook, and LinkedIn. And of course, I want to thank you for listening to On the Evidence, the Mathematica podcast. If you're enjoying the show, I have a favor to ask. Please share it with a friend who you think might like our podcast too. As we cover research related to some of the most pressing public policy issues of the day, we want to make sure we're reaching everyone who values evidence as much as we do. Of course, the other standard requests still stand. Subscribe if you haven't already, and if you have the time, we welcome ratings and reviews. As always, you can keep up with interesting work from Mathematica by following us on Twitter. I'm at JB Wogan. Mathematica is at Mathematica Now.